All right. Thank you, everyone, and thank you for your patience. I really appreciate it. We are very excited to host Sama today here. Sama has been greatly supportive of STEM peers for last couple of years. They supported us last two conferences, and we want to give this opportunity for Sama and Dr. Olchak to introduce some of the questions and some of the work that Sama is doing on fertility. So without any further uh, delaying, Priya and Dr. Ulcha, go ahead, please.
Thank you. My name is Priya. I'm one of the coordinators here at SAMA. I'm also the head of the partnerships. We started SAMA because we wanted to be different, but we also wanted to, improve accessibility to care, improve support. Dr. Olcha is one of our co-founders. He's also our chief medical officer. He's also to be honest, a kick-ass doctor. So we're very privileged to have him to not only support us through this journey, but also to educate not only our patients, but those who we interact with on why it's important to preserve your fertility and also have a really kind of honest relationship with your fertility journey. So you know what your best outcomes are, so you can succeed. And on that, Dr. Olcha.
Perfect. Yeah, thank you. So I am Dr. Olcha. I'm a double board certified reproductive endocrinologist. So in the US, basically to be able to do fertility treatment, you have to go through some training like in many other countries. And here is an OBGYN residency and then a subspecialty specifically in fertility, which is called reproductive endocrinology. And as Priya said, I am also the medical director at SAMA. Which really means that I handle all of the medical decisions that come to play when we have patients come through our system and through our program. She talked a little bit about SAMA. I'll add maybe a few other tidbits. We really started this company with the goal of improving the access to care for women all over the country and maybe one day all over the globe. And the real goal there was, how can we make it easier for not just women, but for individuals and couples to get fertility treatment, to get egg preservation treatment. And we do that by maybe sort of meshing or implementing a little bit of technology, a little bit of logistics, and just some really good care together. And all three of those is what encompasses SAMA. We'll talk, I'm happy to talk more about SAMA later, but that's really the goal of the company. We are a medical clinic at the end of the day. We offer medical treatments. I think what we do is we just do it a little bit differently, and we offer it maybe with the convenience of being able to get the care you need without all of the time requirements that are typically needed when seeking fertility care in this country. All right, everyone can see my slides, correct? Awesome, good. So I'm going to start with just like a very brief foundation on female reproduction. Then I think we could talk a bit about male reproduction, because ultimately to have a child, it takes two. And then we'll talk about maybe some of the different options that women have, either if they're trying to preserve fertility or couples have if they're trying to actually have a child and go all the way. So the female reproduction part, again, I'm going to do my best to simplify this, because this is hundreds of pages worth of textbooks. But to keep it really simple, the way we like to think about it is that each cycle is about a month long for a woman. That's a cycle that they ovulate and release an egg. And in the beginning of the cycle, that's where we sort of see the selection process happen. So what I like to tell women and couples are that you're born with all your eggs. So you have this bank of eggs, kind of like you have all your money in the bank, you have all the eggs in the bank. You're born with a lot of eggs, hundreds and hundreds of thousands. And then each month after puberty, as you have a period and you go through a cycle and another cycle, what your body is doing is it's waking up a few eggs. When you're young, it wakes up a lot of eggs. When you're older, it wakes up less and less eggs. So as you go month by month, you have this bank of eggs. They're all sleeping. They're all in the dormant phase. And then when you get your period, and that's what we call day one of the cycle, there's a group of eggs that wake up. And you can see that here kind of depicted by day one. A lot of these round red structures are called eggs. And essentially, as the cycle progresses, one single egg becomes the dominant egg. It's depicted as blue here, and it grows and grows and grows over the course of maybe a week or two until the middle of the cycle where it ovulates. And then it basically waits to get fertilized. And what we do in the fertility world is we kind of exploit this factor. So what happens in a natural cycle is there's a cluster, a group of eggs that wake up, let's say 10 eggs in the beginning of the month. Your body will ovulate one, and then the other 9 eggs simply dissolve. The entire cohort is lost that month. One is ovulated and the rest really dissolve. In a fertility cycle, what we do is we exploit that by actually giving you additional medicine, or we're feeding the other eggs that would have normally dissolved, and we're trying to capture all of the eggs in one cycle, and that makes it a lot more efficient for us. So this is basically what a full cycle looks like. The difference is that in an actual fertility treatment, from day 1 all the way to ovulation, what's happening is that the patients are generally taking some hormones to get all of the eggs to grow so that we can capture all of them together. When we talk about problems with fertility, we try to separate it into some of the different organ systems. So for the female part, we've got the uterus, which is in the middle. That's what's carrying the baby. You have the fallopian tubes both on the right and the left. Those are attached to the uterus, and that carries the egg inside the womb. The ovary on the left side and on the right, that's where the bank of eggs is, right? Hundreds of thousands of eggs sit in the ovary. And then down below is the vagina and the cervix, which are really the tunnel or the canal into the female reproductive tract. So the basic biology, which I think everyone understands already, is that every month you ovulate one egg. That egg gets captured and travels through the fallopian tube, eventually makes it into the uterus. And hopefully at the same time, if you're having intercourse, the sperm make their way up as well. The issue here is that there could be lots of things that can go wrong here. Some of them are hormonal, some of them are structural and anatomical. So if we just look at the uterus, which is the center womb, people can have abnormalities in that. You could be born with abnormalities where there could be a division in the uterus, or the structure and the shape of the uterus is not normal. Some of those are correctable with surgery. Sometimes what we have are growths, so something that you're not born with, but something that grows over time. And so we have some tumors that grow in the uterus, which are very common, called fibroids. These are benign, very common in almost really any kind of background. Then we can have problems with the structure of the fallopian tube, right? So sometimes these tubes could be blocked, just like plumbing in a house could be blocked. Could be blocked because of an infection that you've had in the past. It could be blocked because some women have had surgery for various things in their life, maybe appendicitis, for example. There are parts of the country where certain infections like tuberculosis are very prevalent, and having that kind of infection can also cause blocked tubes. Of course, if the tube is blocked, that means that the egg can't make its way into the uterus, and that also prevents pregnancy there. The ovaries are obviously a big concern of ours. The primary concern we have with ovaries are really number 1, which is quantity of eggs, and then quality of eggs. And we know that both of those go down in time. So you're born with maybe something like 1 to 2 million eggs at birth, which is a huge number of eggs. But then we know that by the time you reach puberty, a young woman has maybe only 300,000 eggs left. So the vast majority of those eggs have already kind of dissolved even before that woman started to go through a period in a menstrual cycle. And then, like I said, every month there's more and more eggs that dissolve away. And so all of those are located in the ovaries. And so as you get older and older, when you hit the late 30s and early 40s, that's when we start seeing diminishing in the number of eggs and then diminishing in the quality of eggs. And that's a big problem for us. From a numbers perspective, if we're doing fertility treatment on someone who's 40 or 41 compared to someone who's 30, we are going to be able to get less eggs each month, even though we might give them the same amount of medication. Ultimately, we can't pull the same amount of eggs, and so the efficiency of the cycle is not the same. The other thing we see is a quality change. So for example, an egg that we are able to get and fertilize from a 30-year-old woman does not behave the same as an egg from someone who's 40. So things like the risk of genetic abnormalities are different, the risks of the eggs being able to be fertilized and implantation, all of that changes drastically. So those are the, the bigger kind of complex systems we look at on the female side. On the male side, again, it's also complex. You have testicles that are producing sperm. They're also producing testosterone, which is really needed to support sperm growth. And then you have all of the sort of the plumbing that brings the sperm from inside all the way through the body, through the bladder, down, or I should say around the bladder, down through the prostate, and eventually out to the world. And really anywhere in that tract, there could be a problem. When we think about male reproduction, really like the simplest thing that we can do is just do a sperm count. And that's something that we do all the time. One of the nice things with Sama is that we are able to partner with a lot of great companies, and we can actually send sperm kits to the house. And so that means that you don't have to go to a clinic and spend the time in the clinic to collect the sample, which can be embarrassing sometimes and just anxiety provoking for men. And rather we can send you a kit to your house, we can do the sperm count, and you actually ship it back in the mail, and we can give you a pretty good idea within a couple of days. So for sperm, what we're looking at is the number of sperm. That's what you're seeing on the left here, sperm count. We want to make sure that there's enough sperm there. We want to look at the way they move, and that's called motility. Some sperm move in the forward fashion, right? So they're moving straight up, and some sperm are not moving properly. So they're moving in circles, and those are sperm that are a little more abnormal. And some don't move at all. A lot of times we see sperm that are either dead or not mobile. And so we'll look at a percentage of that. Then we look at the sperm morphology. That's the shape of the sperm. We want to make sure that the head of the sperm is sort of oval in shape, that there's a good tail, and that the tail is moving. Some sperm have no tail. Some sperm have 2 tails or 3 tails. It's quite interesting what we can see on the microscope. So, putting the two together, what is infertility? Well, infertility is really defined by the fact that you have a couple who are not able to get pregnant. And there's sort of these 2 age cutoffs that we use. One is less than 35 and one is more than 35 years old. And the reason that there are age cutoffs there is because when you're younger, so if you're under 35, usually what we tell the couple is that, try for a full year on your own. And if by the end of the year you're not successful, it's at that point that you should seek some advice, either with a company like us, like Sama, or another fertility center. When you're older than 35, let's say you're 39 or 40, at that point, we don't want you to spend a whole year trying to get pregnant. What we'd like you to do is try for 6 months, but then if it's not working, then come see us, right? Because at that point, time is really of the essence, and we don't want you to spend a year and another year and another year, and then you come to see us when you're 42 or 43. At that point, there's not as much that we can do compared to if you come to see us earlier. And so that's where some of these kind of definitions come in. The other thing that you should understand is that infertility is quite common. I think that fertility treatment is very taboo, and people don't like to talk about it. People don't like to talk about the fact that they're together with their partner and it's been 2 or 3 years and they haven't been able to get pregnant. But understand that you are not alone. That this is something that affects a huge amount of couples. In America, roughly the numbers are about 1 in 8 couples that suffer infertility. And this is true mostly worldwide. The numbers are about the same. So it's a really important concept to understand that this isn't a very rare thing. This is actually quite a common thing. I think we're privileged to live at a time where we have a lot of tools to our disposal that can really help us with this. I'm going to stop there for a second. I think we're pretty good, but just making sure no one has questions right off the bat. All right, excellent. So another part that I think we should understand is the age factor here. And, I talked about it before, but I thought it was helpful to kind of show a graph to really kind of get the gravity of it. What you'll notice here is the graph is really most steep between 35 and 40. And so while fertility always declines with age, it's fairly a linear decline up to about the age of 35. And then we start seeing this very steep decline. And so that's why when we're talking about getting fertility help or preserving eggs or preserving embryos, the ideal age to sort of save the eggs or save the embryos is before 35. Obviously, that's not always an option for everyone, but that would be ideal. After 35, that's where we start seeing things like lower quantity and lower quality. That's where it gets a little bit more challenging. Now, when I'm talking about age, this is strictly the age of the female, not the age of the male. The age of the male, I don't have that chart up here, but it's a lot more linear, very, very slow. And we really don't see a drop until even later into the 60s and 70s. So it's pretty well preserved in men. So officially, when we look at factors, I like this 1/3, 1/3, 1/3 chart on the left because it really tells us that about a third of the time there's an issue with the woman, about a third of the time there's an issue with the male, and then about a third of the time it's probably a mixture of both or some unknown cause. And so it's unfair to say that it's always the female that is implicated in fertility, even though I think, again, when we sort of like look at social media and we read the news, it's always the female that's getting the fertility treatment. But in reality, what we see in the clinic is that it's about a third women, a third men, and then about a third is just a mixture of both, which is actually very common. So what do we do when we want to evaluate fertility? And this is true not just for a couple that's looking for IVF, but this is also the same kind of evaluation we would do for a single woman who is just looking to preserve her eggs. And we're looking at a couple different things here. So the first thing we do is what's called an antral follicle count. And this is a fancy word for a very specialized pelvic ultrasound. So it's an ultrasound of the uterus, an ultrasound of the ovaries. And what we're looking is we are visually trying to assess the ovaries. We're looking to see, can we see them easily? Are they easily accessible if we needed to retrieve eggs and extract eggs? And how many follicles do we see? And you'll hear me kind of use the term follicle and egg interchangeably here. They are slightly different. Follicles are those early eggs that wake up every month, and those are visible on ultrasound. Eggs, which there are thousands and thousands of, those are not really visible on ultrasound, but they're a good measure of each other. So if you have a high follicle count, you probably have a high egg count, basically. That's the way I would think about it. Now, other things we could do is we could check blood markers for fertility. Really, the main one is called AMH, or anti-Müllerian hormone. This is a blood marker that helps us really determine if a woman is similar, above, or below the range for another woman in that age-matched control. So it's really good to compare and see if you're 32 years old and you're thinking about freezing eggs, is your egg number higher than the average 32-year-old, or is it lower than the average 32-year-old? And that's where AMH comes in. The other really important part of AMH is that it's a good indicator of how many eggs we can pull out or how efficient we'll be. So for example, if I have two women, they're both 32, but one of them has a very high AMH, then likely we'll be able to get more eggs from her compared to the person with the lower AMH. So it kind of helps us assess maybe how many treatment cycles you'll need to do to become successful. There's some other hormones, things like FSH and LH and progesterone. These are all things that we look at. You'll see thyroid here is listed on the very bottom. TSH is thyroid stimulating hormone. That's something that can impact how you ovulate and the quality of those eggs. Same thing, prolactin is a hormone that's made in the brain, affects ovulation and things like that. But really, these are sort of like the main hormones. AMH to look at the total count, and then an antral follicle count to actually visibly see the ovaries. For the male side, it's pretty much what we talked about before. It's a semen analysis. It's where we take a sample and we count the sperm and we check how many are moving, how many are not moving, and the quality of those sperm. There are some blood tests we could do for men, but generally those are reserved for when we have abnormal semen analyses. So let's say you've done all this and you're kind of thinking, okay, well, what are my options? Well, your options are really kind of dependent on where you are in life and what you want to do. So if you are someone that has a partner that is having difficulty getting pregnant, then then we have options like timed intercourse, which is not really listed here, but that is an option. Intrauterine insemination, where we push the sperm into the uterus. Something like in vitro fertilization, which is really sort of like what we consider the gold standard. That's the best of the best. That's the Ferrari of treatments, right? That's what in vitro is, and that's going to get you the highest success rate. If you are someone who is in a relationship that is not a heterosexual relationship, or if you are single, right? In that case, then you might need some donor eggs or donor sperm, because it still takes two to have a baby. And so if you're a woman that's single, maybe you need donor sperm. If you're a single male, maybe you need a donor egg. The other reasons we sometimes use donors is if the egg quality is not so great. So sometimes we use a donor egg if the egg quality is poor, or if the sperm quality is poor, we'll use a donor sperm. So there's some other situations that either a donor egg or a donor sperm is possible, or is a good treatment type. Now, on the bottom right, you see preservation and egg freezing. Those are really kind of saying the same thing there. And what we're talking about is individuals who are in situations where they're not with a partner, they're not married, maybe they're not sure what they're doing for the next couple of years. They're delaying having a child. They haven't found the right person, but they want to preserve their eggs. Maybe you're 35 and you're worried that it might be a few years before you find someone. Well, that's a really great situation where it would be a good idea to preserve your eggs. You can kind of focus on your career, focus on your education, focus on whatever you're doing in life, and not have to worry that by the time you meet someone, by the time you're ready to have children, that your egg quality will be an issue, and sort of buy yourself an insurance package there. There's another thing that's not really listed here. It's called embryo preservation. It's really all part of preservation. But we do sometimes run into individuals and couples who maybe are together, but they're just not ready to have a child right now. And so that's a great option, because you can preserve the embryo, and that gives you a much higher rate of success, because we already have a fully developed embryo. We can do some genetic testing on that embryo. And you're able to preserve those embryos until later in life, where you actually want to have a child. So another great option. So who should do egg freezing? I kind of touched on this, but just to go into a little bit more detail here, we're talking about healthy young women that want to preserve their fertility. That probably accounts 95% of the women that do egg freezing. They're women who are career driven. They're very medically literate. They understand what they want in life, and they want to kind of plan out a little bit. So it's a really great option. Other women that do egg freezing, sometimes we get people who want to donate eggs to a family member, right? Maybe you need to donate eggs to your sister or a cousin or a friend or a stranger, right? Sometimes those are reasons to freeze eggs. Sometimes women freeze eggs because they have some big procedure upcoming. Maybe you have a surgery that is going to be planned. And if that surgery could cause problems with your ovaries, then we might want to freeze eggs before you actually undergo that surgery. Another reason that's not as common, but we do see it, a little bit of a sad reason, is that sometimes you get diagnosed with a cancer and you need chemotherapy. By the way, this is true of men also. And before doing that chemotherapy treatment, sometimes it could be wise to freeze eggs, because certain chemotherapy regimens, depending on what it is, could affect both sperm and egg quality. So this is another reason that sometimes you might want to freeze eggs. What about IVF? Well, we talked about this, right? This is if you're a couple, if you're together with someone, and you've really tried hard to have a baby on your own and it hasn't worked out. And so again, that encompasses 95% of the IVF we do. Other reasons that we do IVF is if you're a single woman or a single man and you want to have a child, that's another reason to actually make embryos and actually go through the entire fertility process. Other than that, if you have some known diagnosis, let's say you already know that your tubes are blocked for some reason, or you already know that you may be too old to try naturally. Maybe you're 43 or 44 or even older. Potentially, if your partner has had a vasectomy or they're not able to conceive, there's some fertility issue there as well. Sometimes we do it for genetic reasons. Maybe You know that you carry this I don't know, sickle cell disease or cystic fibrosis, something runs in your family, thalassemia, alpha thalassemia, beta thalassemia, a blood condition. So in those cases, you might want to check the embryo before getting pregnant. And the only way to do that is with IVF. And then, of course, the last thing is preserving embryos for timing purposes. And that's what I was talking to you before about, where we have couples who are just not ready for kids right now, but they know that they want kids in the future, and they want to make sure that they secure that. So what about the process? So here's what I usually tell people. This says in vitro fertilization on the top there, but truly the process for IVF or for egg freezing is the same. There's really no difference in process for the actual patient. The difference really happens more in the lab side. So how does it work? Well, I would say it is it's a 2-week commitment where for those 2 weeks that typically starts with your period, you are committing yourself to give yourself medication to stimulate the eggs to grow. And those are typically injectable medications that you're given every single day for about 10 or 12 days, almost 2 weeks. And that's what we call stimulation. During the stimulation phase, we have what's called monitoring. And that means that over the course of those 2 weeks, you are going to need to have an ultrasound a couple times and some blood work a couple times as well. And the reason we do ultrasound and blood work as the woman is taking medication is so that we're able to track the growth of the eggs. We start with very, very small eggs. They grow bigger, 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 bigger until they're fully mature, right? And that's the process of sort of monitoring and stimulating. And at the very, very end of those 2 weeks, when you're done with all your medications, we are going to want to release that mature egg, and we're going to want to have it detached from your body so that we can take it. And that's called mature, that's the point where it says mature egg release. Sometimes we call that trigger. When you're coming through our program, you might hear that word as well. They all kind of mean the same thing. So those 2 weeks are the start. And then they end in this process called an egg retrieval. It's really a procedure. And that's a procedure that I do along with some of our partners. It's a procedure where a physician will actually do the egg retrieval. It happens in a surgical center, in an operating room. It's a very safe procedure. It's a very minimally invasive procedure. There are no cuts on your belly. There's no cuts on your skin. There's no scars left behind. It's done typically while you're asleep, very, very light sedation. You're not intubated. There's no tubes in your throat. Really, you're breathing on your own, kind of in this sleepy, dreamy state. That procedure takes maybe 15, 20 minutes to do. It's done with a very, very, very tiny, tiny baby needle, even smaller than an IV needle that you use to draw your blood, for example. And through that needle and with ultrasound guidance, we're able to go pretty much follicle to follicle to follicle, retrieve the eggs. And then from that point, that's where there's sort of this divide. If you are choosing egg freezing, then really it stops there. We freeze the eggs and they get frozen for as long as you want, 5 years, 10 years, whenever you're ready to use them. If you want to make embryos, that's where the step continues in the laboratory, although again, for the patient, the day is done. In the laboratory, we fertilize those eggs with sperm. We find each individual sperm. We put each one sperm in each one egg. We culture them out for about a week until we make embryos. And that's where, again, there's another divide. You could either have a transfer where we put the embryo back in your body and hopefully it sticks, or you can do egg freezing if you want to preserve your embryos, or you could do genetic testing if that's something that, if there's some gene in your family that runs. Sometimes we do genetic testing for things like Down syndrome, which is something that is very common. Sometimes we do genetic testing just to see the viability of an embryo because you want to increase your chance of success and you want to decrease your chance of miscarriage. So that's a very common thing we do. And so if that's the case, we do the genetic testing and we pretty much wait, right? We wait for those results. We wait a couple of weeks. And then once we know which embryos are good, which embryos are not so good, that's when we decide to go ahead and do the embryo transfer. So that's sort of like IVF or egg freezing in a nutshell. I'm going to stop here. I think that was a pretty decent sort of like a primer into the fertility world, into what we see. We're at Sama obviously happy to help out anyone who's watching this. We are able to provide IVF and fertility services as well as egg freezing services pretty much all over the country, from California all the way to New York City. And maybe it's worth it to let Priya talk a little bit maybe about some of our services?
Yeah. So thank you, Dr. Olcha. So some of the things that Dr. Olcha likes to emphasize is things that are, relevant to a lot of the conversations that we're having. I, on the other hand, want to also, harp on some of the things that I've seen over the interactions we've had with different patients, the experiences I've had on my own, and what we hear on a day-to-day basis. I think that egg freezing is amazing. I think it's totally worth it. I think it's definitely a great investment towards your future. And if you're with a partner and you've been with a partner for a while, I think embryo freezing is great. I have this secret mission, just mine alone, to make every couple do embryo preservation on their wedding registry because I think it's a great investment. Grandparents want grandkids. Somebody can help pay for it, right? Because let's be honest, you want to get to know your partner, you want to grow with them before you start a family. And I think embryo preservation is also a great way to do it. So between egg freezing and embryo freezing, I think they're both phenomenal options, especially as you are young in your career and you want to make yourself financially stable, you want to make yourself emotionally and mentally stable to have this journey of having a child. Back in November, my partner and I did a proactive embryo preservation cycle because our lives get complicated, life gets stressful. And so while we're young, we were like, okay, let's proactively preserve embryos. That way, as we get older, and if we do struggle to conceive, we have a backup ready batch of embryos when we were less stressed and younger and able to do these things for ourselves. So at Sama, apologies. It seems like I am forgive me. At Sama, we have that's one of the cool things about Sama. We actually have a phone line that stays open till about 11 p.m. Eastern. And especially if I have patients that are located on the West Coast, Dr. Olcha kind of does stay awake till about midnight on trigger nights so that he can make sure that all of our patients are taken care of and they know what they're doing and no one's struggling. So that's something that's very particular about us. We know that this could be a very daunting journey because you're not really always used to injecting yourself with fertility medication. So we want to be there to support you guys. So at Sama, some of the things that we do are some pretty unique ways to get our patients to be more effective, more successful. We have options that we do for egg freezing and embryo freezing. We do at-home monitoring. We have transvaginal ultrasound about yay big that people can use on their own body and do their own scans. I know that sounds pretty cool and pretty ridiculous, but it's actually really, really nice. You are controlling how fast you're putting in the device. You're also controlling how the movement of the device, but our technicians are taking care of all the measurements, all the pictures. Dr. Olcha is then seeing all the images in real time and making sure that everything looks good. And so these are ways to kind of get your time back in your schedule so that you're not going back and forth to a clinic and being successful where you're located. We do have some IVF journeys. We do have some just frozen embryo transfers. These are couples that have preserved embryos in the past and are just transferring it. We also create embryos. So if you've frozen eggs in the past and you want to create your embryo and then use the embryos on yourself, we do support those journeys as well. Our website's pretty good at having pricing information, but we do try to make the website as interactive as possible. We have some things called an intro to Sama call where you can meet with a coordinator like myself. We can walk through the different options we have. You can meet the doctor directly and kind of get started on your process. We also have something called Self-Start, which is a very cool way for you to proactively work on some testing while you wait to meet Dr. Olcha and the rest of our clinical team. That way you're not wasting your time, you're getting your testing done, and you're coming prepared to an appointment where, our doctors are able to kind of walk you through next steps because they're seeing results in real time. So those are some of the ways that we at Sama have found our patients to be more successful, more productive. I mean, we feel very privileged. We always feel like we have the smartest patients, the most competent, who are very proactive. It's a different demographic of patients than a chronic illness patient, for example. And so we like to capitalize on that because you are tech savvy, you are capable of, being proactive, and this is an elective procedure you're choosing to go on. We can make it way more interactive. We can also make it way more effective so that you're not wasting your time. Our doctors are being effective with the stuff that you're presenting us. And overall, it kind of is smooth and seamless.
Maybe we should tell them the website.
Oh, yes. Our website is sama.life, SAMA.LIFE. Ajinkya can link the links to our pages as well, so you guys have access to that. And then you can always reach out to me in any kind of capacity that you'd like. I'm available on LinkedIn, on our Instagram page. So whatever works for you guys, we're available. I know you guys have a couple of questions. I think
yes, there are a few questions trickling into the chat now. Uh,
Dr. Olcha, are there any side effects of the egg stimulating medicines?
Great question. So the good part is that the vast majority of medicine that we give, they are human derivatives of the hormones that your body is already creating. So most of what we give you are proteins or molecules that basically your brain is making anyways. So the medications don't really have side effects, but I think what we see is that it's really dose dependent. So if we give you a lot of medications, or if you're very young and you have a lot of eggs, then yes, like sometimes what we can get is women who have bloating. That's a very common one. Some people have headaches occasionally, pretty rare, but could happen. Some people can feel some cramping in their belly occasionally. These are pretty rare in general, I would say, but sure, like certainly if you're very young and maybe you're on more of a moderate dose, then you could see some of those side effects. It's pretty rare that I get someone that is nauseous or vomiting, maybe like once a year. But for the vast majority of the time, we don't see too many severe side effects with these kind of stimulation medications, as long as we practice wisely, which we do, and everyone kind of sort of has a tailored approach to the type of medicine that we give them.
Another one, Dr. Olcha. When you show the graph about the fertility declining steeply between 35 and 40, is that fertility only pertaining to egg quality, or other factors that we should also be assessing in overall infertility?
Yeah, so the two factors that are affected most in that age range is the quality of the egg and then the number of eggs as well. So in women, you're only going to ovulate one egg a month, whether you're 30, 35, 40, or 45. There's still only one egg that ovulates. The difference there, though, is that the group of eggs that wake up every month go down and down and down. So that when you're 25, there might be 30 eggs that wake up. When you're 35, there might only be 15 eggs. When you're 45, there may only be 2 eggs. And so the quantity factor between that age group, 30 to 40, really is something that we see when we're doing IVF, because we notice that, in some cases, no matter how much medicine we give you, we're still limited by maybe getting only 2 eggs out. And so that's where we see this sort of like kind of sharp drop there. I just want to add that there's a spectrum here, right? So you could be 40 and have still very high number of eggs and sort of like a very preserved egg reserve. You could be young and have a low number of eggs. And there's no way by just looking at someone to know that. Just because you're 35 and you feel 35 doesn't mean that you have the egg reserve of a 35-year-old. Just because you're 45 and you look 25, right? And you feel really young doesn't mean that you have that egg reserve. And I think that's where something like our Self-Start program is really great. It's because, I think everyone, honestly, at some point, should just get some very basic testing and see where they are, right? And if your egg reserve is amazing, great. Maybe you have a year or two to wait and you don't have to sort of rush. But if you're 32 years old and your egg reserve is low, then this is something that you should know about, and something you should take advantage of.
One of the things that I like to call out is that, right now you're 32, you might be young and work might be going okay, but within a couple of months, work can get really stressful, and stress totally affects the way your egg quality is and how how you age. And so, when you're in a good situation and you have the ability to do egg freezing, I think it's a great time to do it. It's kind of like one of our patients said it beautifully. She called it a gift to herself. It's a gift to her future self, where she felt like she was giving her future self a gift when she was less stressed, when she was able to kind of take control over it. And I think it's a great way to think about it. The next question is actually a great question. It's Dr. Olcha loves this question too. It's a math calculation. So is it better to freeze eggs at 31 or freeze embryo at 31 or 32, but only proceed with implantation around 40? Have you seen a difference in outcomes? And actually, Avanti, I'll add one more layer to that. Is it better to preserve eggs, or is it better to preserve embryos? How do you do math that way? Like, how can you hedge your bets better?
Right. Yeah. This is like probably one of the more common questions we get. I would say it ends up being situational. That's the first thing, right? Because in order to even preserve embryos, you have to have sperm. So the egg versus embryo question sometimes is really answered by a simple fact, which is, well, I don't have a partner and therefore I can't even preserve embryos. Either way, the good news is that today, right, in 2024, which is different from a decade ago in 2014, and certainly different from 2 decades ago, when we talk about and when we look at egg quality that's coming from a frozen egg, or an embryo that's frozen, today they're almost the same. Okay, so one for one, I would say that today, with the technology that we have, I don't think you're losing much by freezing eggs. I don't think you're losing much or you're sacrificing quality by freezing eggs. And so that shouldn't be a concern. When we think about thawing eggs and how many thaw, probably about 97% of eggs will thaw properly without a problem. When you compare that to embryos, it's about 99%. So there's a 2% difference, right? We're not talking about a whopping 20% difference today, right? 20 years ago, you would have got a different answer. Even 10 years ago, you probably would have got a slightly different answer. The other thing I'll say about eggs versus embryos is that, like, ultimately the end game is the same. So if you freeze 10 eggs, and let's say those 10 eggs, you know, we can sort of forecast and magically we know that they made 3 embryos, you have 3 embryos at the end of the day. If you did an IVF cycle and you got 10 eggs and you made embryos, you still would only have 3 embryos. So, I don't think you're getting much more by freezing eggs or freezing embryos. I think, like, the big picture is, if you have a partner, right, then you should freeze embryos for one reason only. And I'll tell you this reason now. And that's because when you create embryos, remember, quality is the same, but when you create embryos, you have knowledge that you don't have when you freeze eggs. All right, let me explain that. You have information, right? You have knowledge that does not exist when you're only freezing eggs. When you're freezing eggs, we can say, we think that 50% will be embryos. We think that 20% will be embryos, right? But we don't know for sure because we only have eggs. We don't know for sure the quality of eggs until we thaw them and fertilize them. So we can predict that 10 eggs might equal 3 embryos, but that's a prediction. But when you are making embryos, we know with 100% certainty that we have 3 embryos, right? That's the difference. It's the knowledge. And the knowledge is actually quite powerful, because if you are 35 and you do egg freezing and you say, okay, I'm going to freeze 10 eggs because that gives me a 50% chance of having a child, then I'm good with that. Fine. So we freeze the 10 eggs. But if you're 35 and we freeze embryos, and unfortunately, when we do the IVF and you get your 10 eggs, we find out that the egg quality is not as good. And when we look at the embryos, there's only 1 embryo, right? Here is where the power comes in. Because knowing that you only have 1 embryo, at 35, you can choose to do another IVF cycle. And now maybe get another 1 or 2 embryos, and now you have 3, which is really great. But if you are doing egg freezing, you don't have that knowledge. You don't know that you may only get 1 embryo when you thaw it. And if you thaw the egg when you're 40, you can't go back in time to when you were 35 to freeze more eggs. So this really comes down to, if you're going to do egg freezing, we shoot higher, right? We don't say freeze 10 eggs, let's freeze 15 or 20, because we don't know the outcome. If you're doing embryo creation, then we say, okay, well, we know that 2 or 3 embryos should be enough, and that's where we shoot for. So it's really more of like a knowledge question, but ultimately, like, knowledge is very powerful in this particular question.
Okay, so there's actually 2 parts to this. I want to answer your question, Avanti, and I want to actually add more information about this. So yes, some insurances do cover IVF. The problem is getting it to, insurances are a tricky game, because you have to be able to qualify for what they have deemed as somebody who can qualify for IVF treatment. So there's like very strict stipulations. You must have been trying for a certain amount of times. You must have tried other treatments. So the amount of like hurdles you're gonna have to figure out is a little higher. Egg freezing, I've rarely ever seen egg freezing covered. Occasionally, employers cover it, which is great. Employers will say, okay, if we're planning to do an egg freezing cycle, we will put, some money towards your egg freezing cycle. There are some other benefits that work. Like, for example, we've seen Carrot, we've seen fertility add-ons like Beyond Med, or Win Fertility. These are like add-ons that your companies can buy. And we actually work with all three of the ones I mentioned, Carrot, Win, as well as Beyond Med. So if you have any kind of fertility add-ons, we've seen a lot more success. We at Sama take insurance for the medication side of it. For the actual side of it, we don't. Fully transparent. It's just a really hard figuring out process for us. And it's really hard for our patients as well. And so we've been able to kind of give great outcomes without having to have that be a part of our conversation. And again, if any of your employers are willing to cover it and you guys need paperwork or any kind of, letters or anything, we're more than happy to help in that way and help, give you guys whatever paperwork you need. And then the second part, actually, thank you, Ajinkya. That was actually my next topic, was actually storage. So we actually do, I love the way that we handle storage, because I think that storage is a great conversation to have, right? Whether you store your embryos for 5 years or whether you store for your 10 years or whether you store it and you end up not using them at all, storage is a question, right? We want to make sure that we talk about future access to this, the access to the embryos, but also being able to move them if you need to, right? We actually store it with a partner of ours called Tomorrow, TMRW, but it's Tomorrow. They're located in the city, in New York City, and they have a very, very cool high-tech storage facility. If you guys are ever bored and you want to see some really cool tech, I would actually go on their website. They do some pretty cool stuff with the robots, and they're really on the precipice of it. They tell you how much the humidity levels are, the moisture levels are. At one point, they even spoke about adding cameras so you can actually see your eggs and embryos. So, they're really on the cutting edge of technology. But because they're a long-term storage facility, they're more than happy to help transport them internationally, transport them nationally. Like, we never know where our life's journeys are going to take us. Today, we might be in the US. Tomorrow, we might be in Europe. We might be in Asia, right? We don't know where this goes. So based on where you guys are moving, we can either move them to where you need them to be, or you guys can come back and do your treatment here, right? They're here, they're safe, they're local, right? The best part about Sama is that, say, for example, you live in Seattle now, but when you want to come back and potentially do it, you want to stay with family in New Jersey, that's an option, right? Because you can technically access our care anywhere. So, we think about it from two perspectives. Either A, we'll work with Tomorrow and you have the Sama team to kind of help figure out logistics for moving your embryos internationally or nationally, or you come back and you plan to do your treatment with us here at Sama. So they'll stay as long as you guys would like. And remember, they're just hanging out in the Big Apple, soaking in the juices of the city. So they're not going anywhere. They'll hang out. And it's a good city to soak in juices. Lots of, good atmosphere, career succeeding people. It's a good city to be hanging out in. So just, we can figure out those logistics based on where you guys are in journey, life, logistics. So
I have one question here from person, and it's related to what is the guarantee, or what is the success rate one can carry of this implanted or fertilized egg later in the year? What's the success rate there? I guess you
you mean
touched
as they
base
get
on it.
older?
Yes.
You mean
Yeah. Can you share some information, thoughts on it?
Yeah, that's a very tough question to just give you a single answer to, right? Because there's a number of factors that go into predicting what a couple's success rate is, right? Because we have to factor in things like what the sperm quality is, what the egg quality is, how they grow, how old the woman is, right? Things like that. I think maybe the better statistics to give you are statistics about, once you have an embryo, what's the chance that embryo really takes? And this is a really great way to sort of like level the playing field when you're comparing clinics to each other, or when you're comparing success rates in this country versus another country. And so, the best metric for me to look at is to say, if I have one embryo, right? If I have one precious embryo in a dish, that we know is genetically normal, right? It's been tested. It's an A+. It looks really good. What is the chance of a patient getting pregnant if I put that one embryo in? And that is going to vary drastically from clinic to clinic. Actually, it's pretty remarkable how much that can vary. At our clinic, at Sama, right, we hover between 75 to 85% per single embryo transfer that's put in. That's probably in the top 90th percentile of the entire country. And it is way, way better than what you will find in most European countries for lots of reasons. But, you'll usually see rates like 40 or 50%. But yes, like if you want a good question, a good metric, for us, for each one single embryo that we put in, about 75 to 85% of the time, that patient will be pregnant and have a positive pregnancy test. There are some other metrics that I always like to kind of throw out there, especially when you're comparing clinics. And probably like the two other ones are, well, what is the rate that you can fertilize an egg? And our fertilization rate is about 80–85%. And again, that's in the 90th percentile for the country. And then what is the chance of even growing an embryo from an egg that's fertilized? And that should be about 50 or 60%. That's going to really vary based on age. The older you are, the lower the number of embryos. The younger you are, the more likely you are to grow embryos. Hopefully that kind of gave you a little bit of statistics. Maybe I'll share one more statistic. This came from a paper that was published about 2 years ago that looked at many, many couples that had embryos. And basically what they found was that if you have 3 embryos in your bank, frozen, then there's a 95% chance that you will deliver at least 1 live baby from that batch. And that's why we sort of go with the 3 number, because that really puts you to like the highest success rate you can possibly get to.
Mm-hmm. Great.
Awesome.
Well, I think I have one question for Priya, and I think you touched base on it, but can you repeat that again? Like in terms of visiting the clinic, you mentioned something about a portable device that patient can use it at home. Can you quickly give us short uh, steps? How many times a person has to visit the clinic? What part they can do at home?
Sure. So, in a traditional IVF setup, a patient comes in quite a few times because they come in for pre-testing, they come in for their meetings, they come in for, understanding their medication, they're coming in for all the monitorings as they're going through. So you actually come into the clinic quite a bit. And the reason why we created Sama was because imagine if you're doing that an hour and a half each way just to get to the clinic, right? Now you're doing about 3 hours a day just to do this, and you're coming into the clinic like 14, 15 times over the course of your entire treatment. So many, many hours of wastage. So what we do at Sama is we do 2 different things, right? We have an option called at home, which I will talk about later. We also have something called remote monitoring. And what we do is we, with our team, find a location near our patients that will do the monitoring for them. So we partner up with we're a national provider with LabCorp. Most of my patients live very close to a LabCorp. It's probably right next door to their supermarket. So it's super convenient for them to go and finish it off first thing in the morning. And then we partner up with OBGYN clinics and radiology clinics near the patient. Most of my patients don't travel more than 25 minutes to 30 minutes each way to get to these clinics. We will book all your appointments for you. We will make sure we get all the data for you. So our patients are really not doing anything. They're just essentially showing up and letting me know that they had a good session. On the other side, we also have patients that do the at-home device. Now, I do have to make a note, the at-home device, you do need to qualify for it. There is a little bit of a guideline as far as making sure that, anatomically you're good to qualify for it, but also that you have the Wi-Fi capabilities and you're able to understand the tasks that are being given to you. But let's be honest, for the most part, my patients are too competent to have this conversation. It's a device by Yay Big. We ship it to your house. It comes with the docking station. It comes with a phone. And that is essentially also the same process. So imagine you would finish your LabCorp in the morning, your blood draw, and then you would do your monitoring from wherever you're located. So if that be your home, that's great. If you are a doctor or a resident and you're doing this in the residency room or something, that's also fine. About on average, a patient monitors about 4 to 5 times on an average egg freezing cycle. Sometimes Dr. Ultra likes to mix it up. If he feels like he wants to see the patient a few more times, it might go up to 6 or 7. But on average, he looks at about 4 to 5 times over the course of that 2-week commitment window that he mentioned. And so all those, 4 to 5 times, you're doing it at home, or at the most, you're going to the LabCorp down the street, or you're going to a clinic nearby. And that's one of the reasons why we are so particular about accessibility to care and supporting our patients, is because our patients are having active lives, lots of strict schedules. It's really hard to make that kind of time commitment to go back and forth. Here, we can make it accessible at their own time. They're doing it at their home where they're working remotely. And so it makes it a lot more of an attainable treatment to have, because it's so accessible and it's so convenient for them.
Great.
And the at-home device looks really, really cool. When I did my procedure back in November, I did the at-home device. It's really cool. You can see all the follicles growing. You can see how the first time looks different than the last time because you have been injecting yourself. If you're even slightly remotely interested in science, it's like you feel like an experiment that you're running on your own, and it's just exciting to see results happen this quickly. Because let's be honest, in a lab, results don't happen that quickly. So it's nice to see it a lot faster.
Let's give a couple more minutes if there are more questions appear. If not, you talked a little bit about your storage facility being capable of shipping eggs and embryos internationally as well. Can you talk a little bit more about it? Like who handles that process? Does Sama handles it, or once the eggs are at that facility, we need to coordinate with them? How does that work? Can you explain that briefly?
So it happens in twofold. Sometimes patients come and tell me that they would like to eventually move the embryo somewhere. So if I preemptively know it, I notify the storage facility team that that is the intention. That way it's already queued up. They already know what they're doing long term. But we also know that, sometimes it's hard to take those decisions, 5, 6 years in advance, right? It could be because of visa reasons. It could be because of career reasons, right? Like you could choose today to move to Spain. You can choose today to move to India. Like that just kind of happens quickly. And it's still fairly easy. Tomorrow does do international shipping. You will always have one of us at the clinic as a coordinator to help assist, because you did do your treatment with us. We have resources on our end that we talk to Tomorrow with. You also have resources at Tomorrow. So what we'd probably recommend is, especially if you're planning to ship it internationally or to another clinic, you start a conversation with all 3 of us. That way you guys have us at the clinic to kind of help facilitate that conversation. The Tomorrow team is impeccable. We talk to them once a week. I spoke to them earlier today. So, it's not like we're not talking to them regularly. So we will figure out the logistics of it. Our only ask is that you figure out exactly when would you like to move it. There's some parts in there that are a little bit more important, especially when you're moving tissue, especially when you're moving very, very prized possession tissue. So it's a very logical process. There are consents involved. There's like a very clear communication of the sending facility versus the receiving facility. So it's a very kind of drawn out process, but you guys have us to support you through it. And both at the clinic as well as on the Tomorrow side.
Awesome. And that kind of brings another question to my mind, because you partner with Tomorrow. Is it possible to someone to pick some other storage facility, or is that something is built in Sama's workflow? How does that?
I can answer that.
Yes.
Yeah.
Yeah, I mean, the answer is yes. Like you don't have to work with Tomorrow. We certainly love them. We think they do a great job, but we're able to ship eggs and embryos directly to another facility. It doesn't have to go to Tomorrow first.
Okay.
Tomorrow is really just a very good long-term storage platform. But we have patients all the time that know in advance that they are going to use a surrogate in another country, right? So it won't go to Tomorrow first. It'll just go straight to that other country from us.
Good to know.
It's also very good to look at costs, and sometimes that actually drives the motivation to use different facilities. Tomorrow's got a very affordable cost. It's also one of the reasons why we partner up with them. We wanted to make it affordable for our patients as well.
Thank you. That's a very good information to know. Absolutely. We have one more question. Does Sama have payment assistance plans, since some of part is not covered by insurance?
Yeah, so we actually, hold on, sorry, I clicking a bunch of buttons. Yeah, so we work with a couple of different finance partners to kind of help do it. We don't have an in-house payment option. However, we work with some pretty great companies that, help facilitate this. We work with a company called Future Family. We work with a company called Sunfish. And we're actually in the works of working with another family called Patient Fi. All three of them are great. They offer pretty decent, listen, the interest market's not great. So the interest rates are not cheap. However, if you do have a good credit score and you're very gainfully employed, they're very accommodating to make sure that this is accessible to them. And the different companies have different limits. So for example, you're a couple, you want to start with potentially one cycle, but then you end up wanting to do a second cycle, they're more than happy to kind of work with you if you need to grow that amount. Or if you don't need to grow it, if you get 2 cycles and you only need 1, to kind of work with you on the plans. And because we have a great relationship on our side, my only ask is for any of our patients that are using our funding partners, let me know that you're in communication with them and that you'd like to work with them. I'd like to give you guys a warm handoff. I'd like to make sure that the finances are not really affecting your stress levels. Our patients that are stress-free have great outcomes. So if I can help kind of, navigate that conversation and make it easier for you, we try our best.
Perfect. It is, are those, is that information available on your website, your partners?
They should be.
It should be, okay. Great.
And on all
Perfect.
3 of the portals, all 3 of them, you should be able to search us to be able to find it. Patient 5 might take a little while because we're literally finding papers now, but the other 2, you should be able to search on Sama and be able to sign up through Sama.
Great. Let
And
me
I can
go
put
back.
those 2 websites here for you guys.
Yes, please.
Well.
I'm just going to go back to chat and check if there are any questions that we missed.
Oh, and just one note, here at Sama, one of the things that we know that can get a little overwhelming is the finance side of it. So we do it very structured. What we ask is we ask our patients to actually spend about half an hour, 45 minutes with a finance coordinator like myself, where we'll review everything. We'll talk about all the numbers, what are potential costs that you might add on, what are potential costs that, you may not have to add on. And so I always encourage my patients to take that opportunity to ask as many questions so that they don't feel like they're lost and figure out the budgets before they start treatment. That way they're not stressed. So we make sure that we do it like a full call that's always accessible to them so they can ask as many questions as they'd like.
Great. Okay. Well, it looks like we have answered most of the questions on this chat box list here. But again, thank you, Dr. Olcha. Thank you, Priya. Before we end, I want to take this opportunity to sincerely thank Sama again for supporting STEM peers. We are a big international community of PhDs and postdocs here in USA at this very important stage of life where we are making these decisions about family and career. And so this is a very close topic to many of us here in STEM peers. And this information has been really, really helpful. And I'm sure a lot of us will benefit from this information and make like very informed decisions. So thank you for that. Thank you again, both of you, for your time. And also thank you all the attendees for fantastic questions and your interest in this topic. If there are no more questions, I think we can also stop here. I'll share the link with both of you as well as soon as we put it on our social media platforms.
Well, thank you for inviting us.
Thank you so much. Have a good night.
Bye-bye.
Bye.
Thank you. Bye.